a keynote address by Dr. Sampat. He'll be talking on Vabysmo experience in diabetic macular edema solution in double whammy. He is a practicing surgeon at Kettering, UK, product of RPC.
Thank you, Ajay, and thanks to the AIOS for this opportunity. And thank you all to make it to the earliest session of the last day, actually. So I'll just get started. I have no financial interest for this session. Now, I think, right at the outset, we have gone through quite a few presentations showing this sort of impact of diabetes and what it's doing to us. This is actually a world map, and what it doesn't show is certain countries in the Pacific Ocean. So these regions, including Samoa, Nauru, they have 1 in 3 of the population have diabetes. So that's the extent of the problem that we are facing. And this is again a slide which part of which was shown by Ajay, just to show what the burden is and what the projection is. A lot of work is being done and a lot more needs doing. No talk on diabetic macular edema is complete without showing you the cascade of events that actually take place. Right at the top, we have the culprit hyperglycemia and the accomplices, dyslipidemia and systemic hypertension, which kickstart molecular biological pathways, leading to oxidative stress through reactive oxygen species, inflammation, and we have an upregulation of all these cytokines and chemokines. And we all know about VEGF, but there are a lot of others as well, including the angiopoietin-2 and etc. So the more we claw into these by down-regulating the upregulation or preventing the upregulation, then we have better outcomes in the patient, because not everything is sorted by anti-VEGF alone. Okay? And there are all these capillary changes that are taking place, leading to diabetic macular edema. Now, we always base our management of patients based on the evidence. And thanks to all these workers coming up with great studies, I have highlighted 2 here. One is faricimab, because I'll be sharing with you the work that we have done at the University Hospitals, Northamptonshire. And I've also highlighted this because we should never underestimate the value of giving proper advice for the systemic control. Okay? And just as an example that Dr. Agarwal just showed, every 1% reduction in HbA1c will give you a 37% reduction in the diabetic retinopathy. So that's very, very important not to forget explaining about the systemic control. So the approval, of course, is based on landmark studies. I'm not going to go into details of these, but just to show that the 2-year gain from this will be roughly about 11 letters. So we started waving the magic wand in our department in June 2023. Surgeons jumped up with joy, and that's me jumping up with joy. But we were just barely recovering from the COVID at that time, so we had a lot of capacity issues. Okay? And thousands of notes were actually looked into to sort out priority, which ones come in first and not. We had virtual clinics with our wide-angle cameras, and we managed to reduce the waiting time considerably. We had one-stop injections, which also helped us, and we designed a treat and extend pathway of the faricimab, which we put up, sort of laminated sheets in each clinic room. So every clinician sort of sang from the same laminated hymn sheet. And that is the, the sheet. So basically all the new patients, had faricimab, and those who were having inadequate response to the other agent were also transferred onto this pathway. And as you see on the left-hand side, you see if you have adequate response to it, then we keep on extending the interval to reach the 16-week interval. If at any point in time we had, inadequate response or a fresh activity, then it goes back into either 4-weekly or 6-weekly, and then we follow the thing based on the response again. So the visual acuities were recorded in Snellen and converted to letter scores, both in the outpatients and the injection appointments. An OCT was performed at each clinic visit. Data was also collected on the HbA1c and the eGFR. So we had 276 eyes of 206 patients in the pathway, of which 141 eyes of 98 patients they had completed the loading dose of 4 injections. And I have all the data on those who have finished the loading dose, so that's what I'll be presenting. So these are the distribution of the sort of gender, the age, etc., and the HbA1c, eGFR. We also just saw, how many of them were graded for the retinopathy one. We found a majority of them with the R2 or the pre-proliferative state, which might make sense because these are probably, liberating more VEGF, and there's more VEGF drive in these patients. And the R3 ones have already been treated with PRP, so the VEGF drive probably reduces after that. So we looked at the 141 eyes, and as you can see, the histogram, all those which are beyond the 4 mark have completed the loading dose. And these are patients with individual number of injections. So we have 31 patients with 1 injection, 56 who 2, and 37 3, and then so on. And a lot of these patients will be shifting to the right. In fact, this data was at the end of February. So by the time I get back, a lot of these would have already had their loading doses and then gone beyond on the right-hand side. So we looked at these patients as switched patients and naive patients. Okay, so we had about a quarter of these patients were naive, and that naive number will keep on increasing because all the new patients will be coming into this pathway directly. And amongst the switch patients, we had a majority of them who have had Lucentis or ranibizumab, and the others as shown in this figure. We also looked at the interval conversion data because it's important to see when they finish their loading dose of 4 injections, how many of them are being able to extend it to 6 to 8 weekly. And we had nearly 90% of these patients going on to that interval. And we had about 5% who continued on the 4 weekly. So these are more sort of refractory cases. And once the loading dose is complete, they come into the outpatients. So there was a 7% of these patients, numbering up to 10, which were yet to have the appointment. So I would expect them to have the same distribution as the other 3. So the change in visual acuity we saw between the switched and naive, and you can see this is important here on the right-hand side. The mean change in the letters was just under 10 for the switched group and about 10.5 letters for the naive group. We looked at the central subfield thickness, and as you could imagine, the naive will have a much greater mean reduction. We saw about 215 microns of mean reduction compared to just under 115 microns in the switched group. We looked at the 70-letter threshold analysis because 70 letters is usually the driving vision. So that's the important sort of threshold. And we looked at all the patients who have completed the loading dose who had vision of less than or equal to 70 letters before, who gained sort of more than or equal to 70 letters after. And we noticed that the number is approximately 1/3 of the whole cohort of patients. But if you look at the the side here in orange, that is the mean reduction in the central subfield thickness is much higher. So basically, this drug has a very good drying capability. And just as a simple example of one of these naive cases, you see a 730 microns reducing straight away to 298 with a single injection. So it's one of the more drying anti-VEGF agents that we have at the moment. We also wanted to look at those patients who actually lost vision. So we had 2 in the switched group and 3 in the naive. But we noticed that most of them actually had significant epiretinal membrane. That was the reason. And one of them in the naive group had quite uncontrolled sugar with about 118 millimoles per mole, which is about 270 milligrams per deciliter. We had no safety issues with this in the DMO group. We did have in the AMD group though, but luckily I'm not presenting that here. We had 1,112 injections of the 276 eyes with no problems. Really, in conclusion, so we are at the mercy of the capacity guillotine, and the real world is always very harsh compared to the trial data. We could have even better results if the compliance is met properly. But faricimab, Vabysmo, has been a significant step towards better patient care. It shows excellent drying capability, fantastic safety profile. Data is still evolving, and in the future, I'll be happy to present the updated data. And this is just a picture of our hard-working team, minus the even harder ones who were not here. So thank you very much.
Thanks, Sampath, and thank you for this wonderful